We are going to start with Dr. Tony. Come on, come on, Doc. Thanks.
All right. Well, thanks, Miriam, and thank you to everybody. It's amazing to see everybody here. I was wondering with the weather. We were out in the snow last night and driving home through it last night. I was worried that this wasn't going to happen, but it's to show this is an amazing amount of dedication on your part, and it's great to see you all here today. I'm very privileged to present before you, and I want to thank you for that opportunity. So what I was asked to talk about was a little bit about life after surgery for cancer, and so let's go right into it. So first of all, congratulations, right? If you've had surgery for cancer, you've been through this and you have come out of it. And by the fact that you're here, you've probably done pretty well. So, and the only reminders you may have now are this, or this, or this, or this, or this. And hopefully that's the only reminder you have, and it's fading over time. And so, we occasionally still get patients who come to us years later and say, I don't feel normal after my operation. And so you're not alone if you're one of those people. So there may be a reason you're not feeling right, and there may be a solution to that too. So what I'm gonna do today is go through some of the common problems. This will be a very kind of 30,000-foot overview. It's by no means a complete list of things that are happening, but what I'm gonna do is go through the different sites that people, kind of the general sites that people have had surgery, people who have cancer have surgery in, and some of the possible solutions. And what I really want to highlight also is who can help you. So if you're having a problem, who's the right person to go to talk about it and maybe get directed to the right place. So let's start with what's near. The two places that are near and dear to my heart are the abdomen and the neck. So I do pancreas, liver, kind of bowel duct surgery, as well as GI, the other GI kind of cancer sites, stomach, small bowel, and those things. But I also love being in the neck, thyroid cancer, and especially. So, so let's start with abdominal surgery. And this picture is what I'm talking about, other than there's a toilet. I was looking for a picture of a toilet, and I found this, and I just could not put it in because I've never seen anything like this before. So. Make of it what you will, but I just really liked it, so I put it in. So, yeah. But there is really a problem with altered bowel habits, and some of these things, especially, can be exacerbated by the other types. Just in addition to surgery, if you had radiation, or even if you're on chemotherapy or systemic therapy, they can be even more exacerbated. But your bowels don't work quite right after the operation, and we try to, we talk about this a little bit at the time of the operation, but things change right afterwards, and it doesn't always go back to what you were before. So what are the possible solutions to that? You can make dietary adjustments, there's behavioral therapies you can do, exercise always helps. There are some medications kind of second line things that you can do. The people you should go to for this are, your dietitians, a gastroenterologist can help with some of the chronic conditions. Going back to whoever, your oncologist may help with that as well, and your primary care doctor can get you off into the right place. But that's kind of, there is more and more, I'm going to talk about patient-centered outcomes a little bit at the end of this, but there's more and more research. We're recognizing this affects people more, more and more. We kind of always, in surgery, concentrated on complications, related to what we thought were important, but we're recognizing that there are things that are important to you guys that we don't recognize very well that we want to try to address better. So I'll try to go into some of those. So this is one that I want to make sure I talk to you guys mainly about bowel obstruction, because it could be an emergency, right? So anytime you have surgery, this is kind of the inside of your belly here. This is the best representation of when people talk about adhesions or scar. This is what we're talking about. It's after any time we do an operation, especially in any cavity, you start forming scar tissue afterwards. And so the scar tissue can lead to abnormal kinks in your intestine, and they may never bother you, and for most people it never bothers you over your lifetime. But what can happen is a bowel obstruction. What is a kink in your bowel caused by the scar tissue that doesn't allow your GI tract to function normally. Things can't pass through the way they normally would from your mouth all the way down to your bottom. So what are the danger symptoms to watch for? So then the common symptoms if you're having this is, it's not, it could initially be mistaken for a GI kind of bug. It's, you're bloated, you might feel a little bit nauseated. You usually don't have fevers or anything right away, so it's a little bit different from that. kind of subtle things at first, but then it's really the persistence of those symptoms that really start to make you wonder if something else is going on. And this is over maybe a day, a couple days, and not getting better. And it's really when you start nausea and especially vomiting, and especially if you're vomiting up not just your food, but you start to vomit up bile, right? So if you're seeing green or yellow kind of things coming up, then that's one of the danger signs. The other is if you stop passing gas, right? So if you had, any of you had surgery on your bowel, if you, in the hospital, we'd every day ask you if you pass gas, and then we celebrate the one time in your life. We all celebrate you're passing gas or you're farting, and that's how we know your GI tract is working, right? So things are passing through because you're always swallowing air. So that air passing all the way through is what you get, is the gas that you pass. So if that's not happening, that's really in addition to these other symptoms, that's what you really got to watch for. There's different solutions. It's not always surgery, and we often try not to operate on people for this because anytime we operate, you form more scar tissue, right? So most of the time, we can get you through without an operation, and maybe the dreaded return of that nasogastric tube if you had one of those before. But it really does serve you right to get into the hospital if it's not getting better and trying to get you through this with some supportive care. So if you're having symptoms like this, the person you should be calling is your primary care doc or your surgeon to talk through the symptoms, and then see if you really need to come to the emergency room or be admitted to the hospital. Sometimes some of these milder bowel obstructions, you just go on liquids for a little bit, and they come back, and things get better on their own, and you don't need to be in the hospital necessarily. But it's better to talk through somebody before it progresses really far, because you can get quite sick from this. So if you've had surgery on your extremities, or if you've had a mastectomy or the kind of chest surgery, muscle weakness and impaired function. So you're weak, you can't do the things that you did before. So there's many possible reasons for this, ranging from whether muscles were cut during the operation to gain access, whether it's nerve kind of related things. So, but in general, physical therapy and even massage can help with these kind of problems. And you should see in this case is the primary care doc, or the person who did the operation may be able to help you too. Physical therapy referrals are great, and often a rehab doctor referral may help you as well. After breast and chest operations, chronic pain is what we hear about on a reasonably frequent basis. And possible solutions in this case, again, are related to physical therapy and massage, medications. This is a great place to talk about alternative therapies, right? So I get asked that a lot is, besides, I'm talking about the things that we know in medical science, and everybody's got a different view on this in terms of alternative therapies. But in general, I'm okay with you guys trying, with the patients that come to me, I'm okay with you trying them. But just in general, if you discuss it with one of us first to make sure it's not something that it might be known to be dangerous for some reason, or something that we know has been debunked already and you're just wasting your money. We don't want to do that either. So it's okay to try most of these things, and some of these things work for people, and that's fine. But I think it behooves you to try to discuss it with us to see if it's something that we can help you figure out if it's the best decision for you. So again, similar people that you should see, and these slides are mainly for reference for you guys here. The other thing, again, that's near and dear to my heart is head and neck surgery. So, and one of the things we hear about a lot in the long term, especially those and Dr. Strauss can maybe speak to this too, is those that have had radiation as well for the head and neck cancers, is swallowing difficulties and voice problems. So, and really, there are wonderful things that speech and laryngeal therapy can do for you for that. So a speech language pathology referral, so they get a swallow evaluation, maybe have people take a look at your vocal cords would be, it can be very helpful and lead to ways to improve that function as well. And finally, I can't not mention lymphedema, right? And usually, not everybody has lymphedema to this extreme, but if you had a lot of lymph nodes removed in either your breast cancer surgery, or if you have melanoma and you've had a lot of lymph nodes removed from your groin, sometimes with pelvic surgeries, this can be a big problem and very impactful on your life. And so the solutions here are, it's compression stocking, massage, not your typical massage, but special lymphedema massage, physical therapy and exercise, and even weight loss can help with these things. But what the second kind of line therapy is there's medications, and there is even kind of palliative surgeries, which aren't common, and really should be a last resort. That's not something you should be going to right away, and you should really be going to a specialized center for that. There's very few, you can probably count them on one hand, the number of centers that are expert at this in the US. And so where do you go for this? This is really what I wanted to highlight, is you see a certified lymphedema therapist. Those are the people that can get you to the right place. Not just a physical, a lot of times I think the mistake that is made is you refer to a physical therapist. These patients are referred to a physical therapist who may know about range of motion exercises and things, but that is not a certified lymphedema therapist. And there's a lot of things that can be done to improve lymphedema, this chronic condition, if you see a specialist in this area. So there's two organizations, and they have really great websites, the National Lymphedema Network and the Lymphology Association of North America. They both certify therapists. They have directories that you can search by zip code to see who is certified in your area, and we can help you with those referrals as well. So I just wanted to, as I told you about earlier about I want to talk about patient-centered outcomes a little bit. This is just our journal. This is the Annals of Surgical Oncology, and this, we didn't, even 5 to 10 years ago, you didn't see articles like this as much, dietary and behavioral adjustments to manage bowel dysfunction after surgery. And again, I think we're starting to realize that some of the things we've been measuring over time, the things that we've been interested in as doctors about improving, care, are maybe not the things that are important to you all as much. Of course, you don't want to have a complication after your operation, and you want to recover quickly from the operation, and you want to make sure that you're selected properly for your operation. But there are other outcomes like bowel function, how independent you are after your operation, how maybe not avoiding chronic pain, what you're willing to trade off to have a good quality of life. These are things that all of us are becoming more, we're recognizing as a more is an important problem that we maybe have not addressed very well. So there's even a non-governmental organization that funds research for this. This is the Patient-Centered Outcome and Research Institute. And this organization, to get a grant, you have to involve patients in your research plan. So they either need to be part of your advisory panel, they need to be active part of your research team. And so we're trying to get patients involved in research more as well, rather than just being the subjects of the research, to be involved in the actual research itself. So you guys are an awesome group for that. So if somebody approaches you about, you're here for a reason and you have a wealth of experience and wisdom to impart to us. So we may be coming to you in the future to talk about these kind of research initiatives, and we'd love for you to participate. So please consider it if that happens. So in summary, you may not feel normal even after years, even years after your cancer surgery. That's normal. So, and there's, your symptoms may have a solution. So finding the right provider is key to get you to the right place. And of course, the Cancer Survivorship Institute is available to help. So I put my kids in every talk so I can distract everybody from how good or bad the talk was. But I want to thank you for allowing me to talk to you guys today. It's a real privilege, and we'll take, I think, questions all together at the end, right? So thank you.
Radiotherapy for breast cancer and radiotherapy to the pelvis, which I do for gynecologic cancers, but is also done for GI cancers and prostate cancer. So it's a pretty common treatment. We'll talk a little bit about side effects that could possibly happen, but usually don't, and what we're doing to treat those when they happen, and even perhaps more importantly, what we're doing to avoid those from happening at all. So I'll start with breast cancer, and radiotherapy for breast cancer is a very common treatment. And in this picture, what you're seeing, let's see, do I have a leader? What you're seeing is a CT scan. So I'll show you on this one. This is kind of a person sliced like a loaf of bread, and here's the spine, and here's the sternum, and so these are the breasts. It's a little flipped in the way we look at CT scans. So this is the right breast, and here's the left breast. And so as I was trained to do radiotherapy to the breast, one of the things that you'll see is that this structure outlined in pink is the heart. And since it sits towards the left side of the body, sometimes when we treat the left breast with kind of our standard fields, we can clip through the apex of the heart. And so that left ventricle, the apex of the left ventricle, and the left anterior descending artery can sometimes be in the radiotherapy field. And what we're looking at here is what's called a beam's eye view. So this is, if you were the radiation beam, this is what you see. And here you see yourself treating the heart, treating the breast, the operative bed, but clipping through a little sliver of heart. And so of course the next question is, well, does this matter? And I won't go through these graphs in too much detail, but essentially what we've learned from some really long studies out of Sweden and the Scandinavian countries is that essentially there is a very small but detectable elevation in heart problems, either in major coronary events or cardiac death from giving radiation to the heart, and that's dose dependent. So here you can see the more dose you give to the heart, the more you elevate this risk of problems. These numbers are actually really small. It's only detectable when you look at large populations, but it's still there, and we still would prefer to not have that problem. So what do we do? Well, I showed you, I'll just go back for a second. This was a patient on her back getting radiation to the breast. This is the exact same patient on her front in what we call the prone position. And so here you can see that our beams are now encompassing the breast pretty well, missing the opposite breast, but also not slicing through that sliver of heart. And so that's one way that we're now using for some patients to try to avoid giving dose to the heart and lungs. Another is something we call deep inspiration breath hold. So in this circumstance, a woman will take and hold a deep breath. And as she fills her lungs with air, pushes the heart down and away from the breast. And so here you can see this is a woman at free breathing, and this red line represents kind of like an imaginary tangent field where radiation is going, and it's getting close to the heart, whereas this same slice at deep inspiration, the heart has moved away from the breast. As we move lower in the breast, again, you could see that a tangent field might be clipping through the heart, but at deep inspiration, we're avoiding the heart, and here we are at the bottom of the breast. So these are two actually relatively straightforward ways. The woman can lay forward, and the breast can fall away from the heart. She can take in a deep breath, and the heart can move away from the breast. Or we can use fancier beam arrangements that sometimes will steer our radiation dose around the heart. And what we know from all of these things is that the lower we get heart dose, the lower that risk becomes until it essentially is probably unmeasurable. And that's really where we're getting nowadays. We also can see when we use radiation for breast cancer, but for other cancers too, that although radiation is really useful in curing cancer, in rare circumstances, it could cause a cancer years or decades in the future. This is really uncommon, but it's not impossible. And of those really rare events, what we can see, oops, let me go back there. Of these really rare events, what we can see is a cancer in that sliver of lung that the radiation passes through. But this is really, really rare in non-smokers and a little more common in smokers. And so I took this picture from the internet, but we like this picture because this shows both the problem and the cause all at once. So this is a CT scan, and here you can see a lung cancer. And you can also simultaneously see that in this patient's front pocket is a cigarette lighter and a pack of cigarettes. So, you know, for us, we might not be able to totally eliminate this risk of a radiation-induced cancer, but one way to lower it from really low to really, really low is to not smoke cigarettes. And if you do smoke, to quit. And I'll move on briefly to talk about pelvic cancers. When we give radiation to the pelvis, we can cause irritation or trouble to the organs that sit in the pelvis. So this can include the genital urinary tract, like the bladder, the GI tract, like the rectum or small bowel, the vagina, uterus, ovaries for a woman, the bones of the pelvis, we can cause a cancer. So all these things are possible, although very rare. So what can happen? We can see some fibrosis in the bladder. We can see it not fill as well. There are medicines we can use for that. We can rarely, very rarely, see focal injury with bleeding. A urologist can cauterize that. We can use a treatment called hyperbaric oxygen to help those vessels heal. Very, very rarely you can see a fistula or connection between like the vagina and bladder or rectum. A surgeon can help to repair that. So here I see we have this little sign, I love my urologist, because working closely with an experienced urologist is a really good way to help treat some of the irritations that rarely, but not never, can happen after radiation treatment. Similarly, we can see irritations of the gastrointestinal tract. Sometimes we can contribute to chronic diarrhea, for which we can have medications, the malabsorption of vitamins, and we can just replace those vitamins if need be. If we aren't absorbing bile salts well, we can use a binder for those. We can cause or contribute to the risk of a small bowel obstruction. And like Dr. Yang said, oftentimes we just try to treat those conservatively, let them get better. If they're not, then my colleague over here can go fix it for us. We can see rectal bleeding sometimes, and a gastroenterologist can coagulate that with a laser, or we could even use hyperbaric oxygen. So again, we would work closely with an experienced gastroenterologist or surgeon as needed if these rare problems arose. We can see problems with vaginal function for women who get pelvic radiation. We can see stenosis, which we try to prevent by giving women a dilator that keeps it open. We can see some dryness, which we could treat with a lubricant or a vaginal estrogen if appropriate. If a young woman loses her ovaries from pelvic radiation, we might, depending on what she has, be interested in some hormone replacement therapy for a while to replace the hormones her ovaries aren't making. And we can also compensate for fertility loss by, we have a really kind of robust oncofertility team that can preserve eggs or embryos prior to this treatment so that a woman might be able to have children in the future, even if we render her gynecologic tract not functional for that purpose. We can see osteopenia or weakening of the bones in people who get pelvic radiation. I like to start everyone on vitamin D and calcium. We can also use bone strengthening drugs if need be. Occasionally we see bone fractures. Those are rare if they do heal. And everyone who gets pelvic radiation has especially if they're young when they get it, it's a very small but elevation in their risk of pelvic cancer. So I like to have people on colonoscopic screening a little more often just to make sure we're keeping track of that. And then, even better than treating these problems when they arise is trying to prevent these problems before they arise. And so we're looking at a variety of techniques kind of in the radiation field to try to avoid this. And here you can see this is kind of a standard pelvic field that creates this box, this square box of high dose, where these in blue are the lymph nodes that are our target. And so we have other techniques, for instance, a fancy technique we call IMRT, where we try to shape the dose more conformally around these targets while sparing the bowel that sits in between them. And we believe, although this is still under study, that reducing the dose to those structures will reduce the risk of these irritations. And that's certainly obviously what we'd really like. And then sometimes we're able to put the radiation right into the cancer itself in a technique we call brachytherapy. And I have some pictures of that, but essentially showing how targeted that treatment can be. And we know that when we're able to use certain kinds of brachytherapy, we see better quality of life measures afterwards when we ask people how they're doing as compared to pelvic radiation. So that's something we use as often as we can. So tools you can use. Tools to take away from this presentation, there are 3. 1, we should always be optimizing our other risk factors. So if someone were to say to me, well, I got breast radiation, what should I do now? To the left breast. If you have diabetes, keep it well controlled. If you have high blood pressure, keep it well controlled. If you have high cholesterol, take a statin, improve your diet, exercise, because reducing your baseline risk of those problems always helps to reduce whatever radiation might contribute. And we should probably do it anyway. If you are a cigarette smoker, hopefully you're not, quit. It will save you money and improve health outcomes. And lastly, I would say pursue long-term follow-up care. Keep coming back to the doctor because if these problems arise, we want to know about it and we want to treat them, and very often we can. And so I got this slide from our survivorship group, but I'll just put in a plug for our survivorship group here at Northwestern. I'd like to follow people with breast, lung, colon, prostate, testicular cancer who've received any definitive therapy, and that they like to keep track of these problems too. Okay.
So I don't have slides or pictures. So unlike my colleagues, my kids aren't quite as adorable right now. They're teenagers, and I'm actually hoping they're out of bed. So I won't show that. But in any case, what I thought I'd comment on, I run the breast cancer program here, and obviously my focus is women, but some of my comments will equally broadly to some of the other diseases that are of concern, and obviously that my colleagues take care of. So when I was reflecting on what I might say that would have some resonance here, I thought about what are the most common things that patients come to see me about after they've completed their therapy. And this may not be the immediate time, but it could be many years later. So there are two aspects to sort of survivorship and recovering from therapy. Obviously, it's the acute phase. So even my colleagues discussed, post-surgical, post-radiation changes that can occur. You get over those. That is also the case with many of the therapies that we give in the medical oncology realm. And I'm sort of coming from it as a breast oncologist. So for many of our patients, they receive chemotherapy for early stage disease. There are short-term consequences to that that many of you are familiar with, anything from hair loss to blood counts going down, perhaps some short-term nausea that can be experienced with chemotherapy. So these are things that are quite common in the therapy that's chosen, and we know that over the short term, those things will disappear. But more importantly, there are consequences that can be long-lived that we still tell patients that they will overcome them. And again, thinking about what are the common things that people come to us with, and in my own practice, women, probably the most common thing they say is, I'm tired and I don't feel like I've regained my level of energy that I had prior to this whole thing that I've gone through. And it's also true of all other diseases where we use systemic chemotherapy. And if you actually talk to an exercise physiologist in patients with early stage disease, be it breast cancer or something else, that undergo chemotherapy, their level of function, their exercise tolerance declines significantly over the course of their short-term therapy. It can actually be documented. It's not just saying I'm tired, but they can actually put metrics around it. So if you undergo therapy for 3 or 4 months, you're going to have a recovery time, not unlike an athlete who is injured, who seems to lose muscle mass and exercise tolerance. And it's something that doesn't, even though we try to convey to patients, you will recover from this, it's not something that happens overnight or necessarily within a couple of weeks. It's actually, there are now programs and research programs about rehabbing cancer patients from the standpoint of exercise tolerance. So one of the things that Jonathan mentioned at the end, including diet and exercise, these things have a direct relevance to your recovery from any therapy, and certainly in our area, breast cancer, patients who undergo chemotherapy for early stage disease, we strongly encourage them to exercise, not only because it may have some impact on disease recurrence, having ideal body weight, less fat, et cetera, but more importantly, just being able to function the way you did before. So again, exercise is critical, and it's not something that's a recovery time that's measured in a few weeks. The other thing that sometimes patients will complain about is this notion of feeling foggy after therapy. And again, it's probably most commonly thought of to be associated with breast cancer therapy, but it's more broad than that. So this notion of chemo brain or even endocrine brain. So many of the therapies we give aren't necessarily chemotherapy, but they're anti-hormonal therapies. This is a poorly understood, poorly defined entity. It does affect some patients where they just seem to be more foggy than they were before. So their mental acuity, their ability to think, process, may be a little less. And for the vast majority of patients, they do indeed recover to their baseline. We don't know how to predict who those patients are that might experience that, but we do obviously tell them, there are certain things we can do to have you evaluated, but generally it's the tincture of time that these things hopefully will go back to normal. And it is something that occurs in only a small fraction of patients. Some of the other consequences of therapy that would apply broadly when we think about systemic chemotherapy, many of the drugs we use have not only short-term consequences that I mentioned, but there can be things like neuropathy. This is something where your sensation in your finger or toes may not be exactly the same as it was before we started. In other words, numbness or tingling. Those extremes can be present. Sometimes patients at an extreme may be dropping things or unable to do fine motor type function like buttons. And this is a consequence of certain therapies that we give. And there are things that can be done for that, including passage of time, which generally does cause some resolution of those symptoms. But there are also medications that can be tried, and we also rely on things like acupuncture in some patients, which is quite helpful. So these are some of the longer term effects. Now in women, one of the consequences of our therapy, particularly in younger women, is those that weren't postmenopausal, we drive towards menopause. Now that can be a good thing from a breast cancer standpoint, depending on the type of breast cancer. But for women who've undergone menopause, telling somebody that they might experience that 15 or 20 years earlier than when they planned on experiencing it isn't necessarily a big selling argument. So hot flashes, sexual dysfunction, those sorts of things are things that patients may experience over a longer period of time and much earlier than they would have otherwise if they went chronologically through menopause. So I think we have to be aware of that. And of course, the other consequences as a direct relationship to having less estrogen around. So that may be good for breast cancer therapy as an example, less estrogen in certain types. But it also can have some impact on bone health, and you heard a little bit about that earlier. So if you have bone density that is not optimal, you're at risk for fractures. And that's a more common problem in postmenopausal women. But if you take somebody who's 40 or 45 and now you make them postmenopausal, you have to be much more vigilant about their bone health at an earlier time point. And as a result, you have to look at bone densities, you have to add calcium, vitamin D, and perhaps other things as well. Patients will often describe quality of life issues. And again, I'm thinking a little bit in a female population. Sexual dysfunction as a consequence of entering menopause early. So vaginal dryness, things like that. So when we meet with people, we always try to include that in our discussion because those are quality of life issues that have an impact. And again, there are certain things short of giving people back estrogen that can be done to enhance their sexual function. Jonathan talked about cardiac dysfunction as a result rarely in patients who get radiation therapy. Similarly, there are therapies that we use for breast cancer, chemotherapy and antibody therapy that can have long-term effects, rare, but they do happen, so we follow their cardiac function over time. And then in closing, probably the most common thing that we try to encourage patients to do is to really get back to their routine, not only from the standpoint of it allows them to have a diversion from the diagnosis, because one of the most common questions that we encounter, particularly in early stage patients, is how do you know the disease is gone? And it's very frustrating for many patients to not understand or not grasp, why can't we do a test or a blood test, or why aren't you doing lots of tests? Because they've never been able to demonstrate that they're useful, at least in a breast cancer disease group. In other diseases, whether it's testicular cancer or colon cancer, the rules may be somewhat different. But we try to get patients less fixated on the concern of recurrence. We agree, as Jonathan said, we want you to follow up. We want you to bring us your concerns or any symptoms you have. But we want to get away from the idea of doing lots of tests in patients who are otherwise well. Because what it does is it creates anxiety, but very, very, very rarely does it ever provide anything useful in terms of information to us that helps us take care of you. And it always creates anxiety, more for you than us. So I think that as we go forward, as we think about the therapies we have, we always are cognizant of what will be the long-term consequences. And one of the programs, again, Jonathan showed you the Survivorship program, which we encourage all our patients, not just breast cancer, to participate in, because it helps sort of take an inventory of standard medical issues, not just the cancer, risk of cancer recurrence, but are you getting your bone health evaluated? Are you having your cardiac function evaluated? And knowing what to expect, what the time frame for evaluating, being seen by your different specialists, so that you have a very clear idea of how you'll be followed, as well as what you've went through. So they summarize your entire treatment plan. And that's actually something that we're required to do now to generate that kind of survivorship plan for patients because it allows them to have a better understanding not only of what they went through, but what they can anticipate going forward. So with that, I'm going to stop. My comments were meant to be general, and hopefully as we get to the end, we'll have questions that we can all address as a panel. Thank you.
You addressed the importance of exercise, and my question was, is there a metric that patients can use to identify when it's appropriate to begin exercising after treatment?
Well, I think some is better than none. More is better than a little. That sounds like it's a gratuitous answer, but the point is that getting up and doing anything does have some contribution to getting back to your level of function. Now, more specifically to your question, when is it okay to start? I mean, you know, from our standpoint, we do have patients in the midst of therapy that we encourage to do some form of exercise. It's not the time to train for a triathlon, but, you know, walking around the block is better than sitting in a chair. So I think that if you get clearance from, you know, the post-operatively that it's okay to do something, we encourage it. I think we try to escalate the exercise or encourage people to dial it up a little bit as they recover. And I think, you know, there is some truth to the fact that, you know, really to recover, you got to push yourself. If you were in the rehab institute following a stroke, patients always say they exhaust me over there. And the reality is that by the intensity of the exercise, they recover their neurologic function much better. And I think the same is true when we talk about how patients recover following some of the things we do. We try to push patients, encourage them, and there are specific metrics that an exercise physiologist might offer you, but there are exercise programs through the survivorship program. They'll give you an outline of what you might expect to do. I don't know if you guys.
What? I'm sorry, go ahead.
So I think after surgery, it's a little bit different. In the long term, you should be able to return to, in general, kind of full function. It's in that kind of recovery phase after your operation where it's really important that I think that you, we want you to be up and around. You know, even if those of you that have had surgery, you know that we don't want you laying in bed. Right after the operation, we want you walking. We want you, you know, kind of light exercise kind of things, being, you know, normal function. But in terms of those of you that want to pursue heavier exercise programs, it kind of depends on the operation. Because, say, for instance, if you had reconstruction after a breast cancer operation, then your activity with that arm may be a little bit more limited for a while in order to get the best possible outcome for your operation. So it really takes a lot of discussion with your physician and your surgeons, and finding out what you're cleared for. And I think a lot of us are going towards clearing you a little bit earlier to push it and just using common sense. And in general, common sense is pretty good. You know, if it hurt, I tell a lot of people if it hurts, you probably shouldn't be doing it. You know, if you have stitches, if it's pulling on your stitches, you probably shouldn't be doing that either. So, but really, it's in consultation with your physician, with your surgeon, because I think it's a little bit different for every type of operation you have. So we think it's less than an open operation. That doesn't mean it doesn't happen, but it's definitely less because you have less of an incision because a lot of these adhesions come from the incision itself and how much manipulation you're doing. And so we know that it's less, and probably there's not great long-term data on this, but we think probably the number of bowel obstructions is less too. Yeah, so, you know, asking about is there a minimally invasive option for me if you're supposed to have an operation, it's not bad. It's not always appropriate in every circumstances, but it's a legitimate question to ask.
What of cancer is now found in males, and is that group percentage rising?
So breast cancer in males is still distinctly uncommon. You know, there's a few hundred cases a year. So that is dramatically less, and it's not really changed in any statistical fashion, meaning the incidence over time, and in a meaningful way.
I'd like to give a quick shout out for Northwestern. I was diagnosed in January in one of Boston's leading hospitals. People come from all over the world, and I was really reluctant to leave my team there, even though I was moving here. And they were very encouraging. They said, quote, Northwestern has some of the very best breast care in the country. And I just wanted to share that as great as my team was there, I think my team is better here. And I really mean that. And Dr. Gradishar is my oncologist.
So for the announcement.
No, I didn't even know you were going to be here. So, but here's my question. I had a bilateral mastectomy, and there are a lot of support groups for women with breast cancer, but I have been really surprised and even dismayed that there aren't many groups. I haven't even found one, and this is in the Chicagoland area, for women post-mastectomies. And 1 in 8 women in this country have breast cancer, and mastectomies are on the rise. And it's not a criticism, it's just that there's so much wonderful resources here, particularly with Northwestern, that I'm just sort of pleading for a support group for women with post-mastectomies.
How do you identify what foods have soy in them? I understand I was told not to eat soy, tofu, or whatever. So there's so many foods that have, hormones and soy in it. How do you identify?
Well, what I would tell you, and hopefully the one thing you leave this with is don't worry about it, because it's in everything. So, with that said, we don't discourage people to eat tofu. We don't discourage people to eat miso soup. It's in everything. The amount of dietary estrogen, which are like phytoestrogens, these sort of like estrogens, are unlikely to have any major impact, not even minor impact, on the risk of recurrence. So unless you have devoted yourself to tofu as the only food you eat, I think the odds of you having any consequence to eating small amounts of tofu, which are broadly in lots of things, is inconsequential. So I wouldn't worry about it. Go to a Japanese restaurant immediately after you leave.
My question is for Dr. Gradishar. Did you say it's possible to have cognitive impairment from anti-estrogen drugs? Did I mishear you?
It's been described. It's not common, but some people do describe a fogginess, and that's
a little fogginess, but then you get over it eventually.
Most people do.
As time goes on, you take the drug more.
Yes.
Thank you.
Good morning. Thank you all for being here this morning. We appreciate it, I'm sure. I have a quick question regarding an article that I saw in MedPage 4 months ago for Dr. Gradishar based on the Early Breast Cancer Trialists Collaborative Group. And I wonder if you could help me understand, just in 2 minutes or less, the recommendations of using an AI, switching to an AI versus tamoxifen, and whether or not you have augmented your recommendations since then.
So for what kind of disease? Breast cancer?
For ER-positive breast cancer.
So that's been a common recommendation in postmenopausal women for the last decade. So in women who have hormone-sensitive breast cancers, early stage disease, 25 years ago, the only therapy was tamoxifen, and then aromatase inhibitors, which are another pill form drug that reduces levels of estrogen in postmenopausal women, were shown to be slightly better than tamoxifen. So it's been very common for the last decade to do exactly that. Nothing new, no.
I think that our time is coming to an end, so I think we can have one more question.
Rectal cancer.
Okay, well.
Do you recommend anything to help replace some of that lost energy?
Exercise.
Yeah.
It seems counterintuitive, but one of the ways of building your exercise capacity is by exercising even when you don't feel like it. We all know that if the last thing we want to do is go to the gym and then we go, or we feel better after we did it. Same thing with patients.
Yeah,
I agree. From the radiation standpoint, we have a couple of studies now looking at a variety of different forms of exercise as combating radiation fatigue, and it looks like they all work. Walking, yoga, everything probably works, any form of exercise.
Thank you so much. That is going to be our conclusion to the panel. So thank you. One last round of applause.